listening to Mending Minds from LINNC Online, the podcast where we delve into the latest advancements in research in neurointervention. I'm your host, Dr. Nanthiya Sujijantarat, and in this series, we'll be discussing cutting-edge technologies and their implications on the future of medical treatments. In each episode, I'll be joined by an expert guest who will share their insights and experiences. This program is supported by Medtronic. Let's get started. Today in Mending Minds, we will dive into the treatment of saccular intracranial bifurcation and sidewall aneurysms. I have my special guest with me, Dr. Markus Möhlenbruch. How are you today?
I'm good, thank you.
Before we dive into the discussion, would you mind giving us a brief introduction of yourself to our listeners?
Yes, I'm the head of the interventional section within the University Hospital of Heidelberg. It's one of the biggest centers in Germany and actually in Europe. And I'm based there since 2011, and we offer all different kinds of neurointerventions you can have.
To kick things off, can you share your approach to the management of saccular intracranial aneurysms in your clinical practice, particularly those located at the bifurcation and sidewall locations?
Yeah, so basically what we look if we have bifurcation aneurysm is how can we treat the patient with the lowest rate of complication on one hand, and on the other hand, to achieve the best result. In my mind, it's still nowadays probably the best combination if we take a device where we can treat just the aneurysm and not the parent artery, meaning, of course, you can coil the aneurysm if it's really small necked, but let's say if you have more a wide neck, so 3 millimeters or more, then you can think about an intrasaccular device. And the beauty of this technology is that you can avoid an intracranial stenting, and this means at the end there is no need for an antiplatelet therapy.
And in your experience, what are some of the key challenges in treating these aneurysms, and how do you navigate these complexities to achieve your outcome?
Yeah, basically, if you have a bifurcation aneurysm, it could be the case that the access to the aneurysm is very straight. Then it's more or less an easy case in terms of navigation of the microcatheter. Then, of course, it depends a little bit on the aneurysm itself, if it's more spherical or irregular in shape. So there are, for example, intrasaccular devices which can be used in more spherical shape aneurysms. And then you also have devices nowadays, for example, the Artisse Device, which conforms a little bit better to the aneurysm, even if it's irregular in shape. So this is something what you have to figure out before which kind of device you like to use. And then, of course, if it's, for example, offset, meaning that the entrance into the aneurysm is tilted to one direction or the other, you have to work a little bit with a microcatheter. For example, you can steam shape the microcatheter. It also depends on the size of the microcatheter you have to use for the different devices. Usually it's better to use the smallest available microcatheter. This is all these different points you have to take into account in your decision-making process.
So you answer a little bit about what I'm about to ask, which is patient selection. So those are some of the factors that you consider when you consider the type of treatment. Is there any other factors that you can share with us that you consider when determining the most suitable treatment for a particular type of intracranial aneurysm? And how is your kind of general strategy in tailoring this approach?
So basically, since we know from different studies, when we use an intrasaccular device, the rate of complication is very low and the rate of occlusion is high. There is a strong tendency, not only in our center, also in other centers in Germany and France and all over Europe, that there is definitely a higher rate of use nowadays of an intrasaccular device, because it's usually very easy to use. The procedure time is very short and the complication rate is low. And then it depends a little bit on the anatomy of the aneurysm. And for this, now we have 3 different intrasaccular devices available. And the latest one is the Artisse Device, where we investigate a little bit more in the last couple of months. And here we have a really good experience with this device in terms of conformability, for example, of the device to the aneurysm.
So at LINNC Paris 2024, which is where we're recording now, you presented the results of your experience with this device, including procedural safety and effectiveness, as well as outcomes. You talked a little bit about the features of this device, but I'm curious, compared to your experience with the other intrasaccular device, was there any particular aspects of the deployment or anything that is different for this device?
Mm-hmm. So if you look to the deployment, then usually the beginning is very similar. So you start with the unsheathing, you see a flowering of the device. So that's similar, I would say, to every kind of intrasaccular device. Because of the proximal part, which is more shaped like a V, it's usually not popping off out of the catheter. It's still a smooth deployment. You continue until the end, until the proximal end of the device, and that's it. And this is actually what we also see from the Inspire registry, from the data. For example, if you look on the numbers, how many attempts were necessary in order to place the device inside the aneurysm, the Artisse device, it was very low. So in more than 50%, it was just one attempt. And another 40% a second attempt was necessary in order to have a satisfied positioning of the device inside the aneurysm.
And was there any criteria in terms of how experienced operators must be?
That's a good question. Basically, if you have experience with other intrasaccular devices, then from my point of view, there is no need to have a super dedicated special training. I can tell you, in my center, I used it in the first 3 cases. And then, because a couple of my colleagues, they also have experience in using, for example, the web, I showed them how to use it, and then immediately they were able to use it.
And how do you approach sizing with this device? Is there any difference compared to the prior?
Sizing is always a question where you can discuss a lot. So basically, of course, there's a sizing chart which you should use. It's also possible to use a software which gives you a nice recommendation. We, at the moment, we use both. And basically, we follow the recommendation which tells us that we have to use the larger device. And this would be I think this is one of the key features that you should know. If you have the choice between a smaller or a larger diameter, take always the larger diameter. So for example, if you have a 5 millimeter aneurysm in diameter and the software or the sizing chart tells you take 6, 6.5 or maybe a 7, go always for the 7 in diameter, but then probably you have to reduce the height of the device a little bit. And this was also explained to us from Vincent Costala. If you look to the compression of the device, the compression is much higher, and hopefully this is one of the key features in order to prevent recausation over time.
You talked a little bit about Inspire registry. Would you mind sharing with us the public clinical data that you have so far?
Yeah, so the Inspire registry is an international multi-center observational registry in order to look at safety and efficacy of different devices, and in this case of the Artisse device. So here at the moment we looked at 87 patients which were enrolled into this study. That was at the time when we analyzed the data in April. Until now, more than 115 patients are enrolled. And it's at the moment just the data about the procedural safety and let's say the short-term follow-up. If we look to the procedural safety, then we were surprised because the rate is super low. So there was actually a rate of 4% of procedure-related severe adverse events. And so 4 cases, 3 out of these 4 cases had actually an access site complication where a surgical intervention was required. And only in 1 case, there was an aneurysm rupture. And this case was also counted as a device-related severe adverse event. The Artisse device was not deployed, but probably the aneurysm was ruptured because of the microcatheter. So, but overall, the complication rate of the procedure was very, very low.
And what about the occlusion rates?
So for the occlusion rates, at the moment we looked at 35 patients. So this number is very limited. Of course, if you know that now more than 115 patients are treated with the Artisse device. But in these first 35 patients, we observed a complete aneurysm occlusion in 80%. And this means a complete aneurysm occlusion. It's not complete plus adequate, which is a difference.
Right.
Here it's 80% complete aneurysm occlusion.
Raymond Roy.
Correct.
One. Okay. Thank you, Dr. Möhlenbruch, for your time today.
Thank you.